Um, my name is Pouya Alaghband. I'm a consultant ophthalmic surgeon based in York Teaching Hospital, which is located in the far north of England in green, lush Yorkshire. Um, I'm going to talk about diabetic retinopathy, and I would encourage everybody to utilize the chat function to communicate and make it as interactive as possible during the meeting to reduce the tediousness of the topic. So what I'm going to cover this afternoon, or depending on where you are, morning or evening, I'm going to talk about diabetes and blindness, what we can do to prevent it, whether there's any role for early diagnosis, and what kind of treatment options are available. So as we all know, diabetes can affect any end organ, be it peripheral limb, kidney, or eyes can get affected in diabetes. And the number of patients with diabetes are set to rise, especially in Middle East and North America and low-income countries, and also some parts of Southeast Asia. There was a study which was published a few years ago in BMJ, and they predicted that the number of the patients with diabetic retinopathy is on the rise, especially in patients with diabetes type 1 compared to type 2. And the rates would be higher in more deprived area and in minority ethnic groups. And annual screening, which was set in 2004, was recommended for all patients over the age of 12 in the UK. So what is the mechanism of diabetic retinopathy? So essentially, in diabetes, because of the raised sugar level, that becomes a toxin to any organs in the body, including the blood vessels, whereby the sugar is just streams through the blood vessels. And what happens is two main pathophysiology happens. One is occlusion through the thickening of basement membrane, endothelial cell damage, changes in red blood cells and platelets. That's the occlusion side of things. And then with respect to leakage is due to loss of pericytes. Essentially, they are like a little scaffolding keeping the blood vessels intact and leak-proof. So this is a picture of a healthy eye. In fact, this is the picture of my fundus. So when we are dealing with diabetes, it's not only the high glucose level, but also other cardiovascular risk factors such as raised blood pressure and high lipid profile can contribute to the capillary damage in terms of leakage and the blockage of the capillaries, which can all lead on to maculopathy. So essentially, diabetic retinopathy not only can affect the central part of the vision, but also can affect the peripheral part of the vision as well. So what I'm going to concentrate now is on the maculopathy side of things. So when the leakage happens, as I alluded earlier, we've got loss of pericytes. And what happens is all the material within the blood vessels start to leaking out, such as lipids and exudates, and the appearance are like yellow deposits within the retina, which we call them hard exudates. So the typical picture of the hard exudate within the posterior pole of the eye in the right-hand side, and you can also see little bleeding area within the retina as well, which we call the microaneurysm. And this is the fluorescein angiography. Again, the white dots lighting up within the fluorescein angiography in the retina pointing to microaneurysm and localized leakage area. And this is OCT scan, which is optical, computed tomography of the back of the eye. Normally, what you should be able to see on the top left-hand side on the picture A, everything, all the layers of the retina should be sitting on top of each other, and you should have a little central dip, which is macula, whereas in the following pictures, you can see there are little cystic areas starting to form as a result of fluid collection in the back of the eye and the leakage from the capillaries. So any questions in terms of the leakage side of things? As I said, feel free to use the chat function to communicate. So very well, let's concentrate on the occlusion part of things. When we talk about occlusion, that means that the circulation is cut off in specific areas, and it manifests itself as a ischemic area. Again, another floating angiography. Normally, you should have the central part in the posterior pole lighting up and being pale white rather than black. You can, whereas in this case, you can actually see small areas of relatively large areas of dropout and ischemia within the posterior pole. So what is the mechanism? So essentially all those toxins within the body can damage the capillaries, and that can subsequently compromise the circulation to the retina and starve the retina. And that sends some signals to the body within the eye to produce more blood vessels, to bring more nutrients to the eye. Therefore, that triggers a vascular endothelial growth factor, which creates new blood vessels, but the quality and the quantity are not as good as normal blood vessels. We call them new blood vessels or neovascularization. Depending on what part of the eye is affected, whether it's in the back or in the front, we've got different manifestations of this. So, for instance, if it happens in the back of the eye, at the optic disc, we call it neovascularization of the disc, in short, NBD, or if it happens in localized areas of the retina, we call it neovascularization elsewhere, or NBE in short. If left untreated and become more florid, can lead on to retinal detachment. They can bleed, as I said, because the quality of these blood vessels are not as good as normal blood vessels. And if they happen in the front of the eye, we call it neovascularization of the iris, or neovascularization of the angle, or rubeosis, which can cause a raised intraocular pressure and can cause glaucoma. So essentially, this is the main mechanism of affecting the peripheral retina and can lead to proliferative diabetic retinopathy. And in fact, the term proliferative diabetic retinopathy is derived from the production of new blood vessels, hence proliferative retinopathy. So let's have a look at some diagrams. So this is, as I mentioned, if these new blood vessels start to grow at the level of optic disc on the bottom right-hand corner, we call them neovascularization of the disc, NBD. If it's elsewhere, it's NBE. So that's the back of the eye, which we call it proliferative diabetic retinopathy. If it's left untreated, can lead up to rubeosis iridis or rubeosis of the iris. And that's all due to the hypoxic retina. Can somebody tell me what is happening in this picture? Would anybody like to share their wisdom with us? Feel free to use the chat function. So do you think this is normal or abnormal? Any takers for normal? Yeah, it is abnormal. Yeah, absolutely. There are florid abnormal neovascularization on the edges of the eyelid, edges of the pupil. And in fact, the first area where you notice, yep, there is a synechia as well. Well done. Yeah, absolutely. Well spotted. There's a small area of adhesion between the iris and anterior part of the lens. So essentially, the first part of the iris, which can demonstrate abnormal blood vessels is pupillary margin. Therefore, if you're looking for the neovascularization of iris, you need to look at the eye before dilation. So you need to first have a look at the eye, assess quickly at the pupillary margin whether there are any, or determine whether there are any neovascularization of the pupillary margin, then dilate. So in this case, you can see abnormal florid blood vessels. So these blood vessels are erratic in terms of the pattern of distribution. They are more twiggy. They are more prone to bleed as well. And they start growing in places where you wouldn't expect normally to see any of these blood vessels. And this is the cartoon demonstration of NVE, the peripheral retina, dot and blot hemorrhages, and hard exudates. And also you can see the bandwagon changes at the blood vessels level, not only because of diabetes, but also could be due to high blood pressure. How about this one? Do you think this is normal or abnormal? Where are we looking at? Is it in front or in the back of the eye? Or is it the eye? Yeah, abnormal retina. Yeah, absolutely. So what is abnormal about this photo of the retina? What can you see here? Yep, absolutely. The eye, essentially, there is so much abnormal blood vessels distributed in the back of the eye that you can barely see any normal retina within it. So there are loads of blood vessels at the level of optic disc. Oh, sorry. And loads of abnormal blood vessels scattered in the retina elsewhere. So essentially, this is a florid neovascularization of the retina. So you would hope not to see these kind of pictures much in this day and age with the access to the screening, but you'd be surprised how many of these cases would pitch up in the clinic. And this one, there are fronts of neovascularization on the peripheral retina. So essentially, they signify the areas of ischemia which had sent signals to the retina to produce more VEGF. Hence, in these cases, sometimes we treat them with anti-VEGF treatments such as bevacizumab and ranibizumab as well, Avastin and Eylea. So now that we covered about the rates and the pathophysiology of diabetic retinopathy and blindness, we can move on to a prevention part of diabetic retinopathy and its consequences. Before I move on to the next topic, any questions about the mechanisms and rates of diabetic retinopathy? Okay, let's move on. So one of the indicators of diabetic control is hemoglobin A1C, and there are loads of studies, loads of landmark studies showing that the lower the hemoglobin A1C is, the better that would be, and the benefit starts appearing at least roundabout below 9 and 10 hemoglobin A1C. And also, there are subsequent studies looking at effect of blood pressure control, whether it's tight or better, lipid profile control as well, which have beneficial effect on diabetic retinopathy prevention. Also, there are significant bodies of literature showing that smoking is a big risk factor for developing diabetic retinopathy. So essentially, you need to actively encourage patients and counsel patients about smoking. So that's essentially prevention of end organ damage starts with the diagnosis of disease itself. But early detection plays an important role in the preventing the devastating consequences of diabetic retinopathy. And that's when the screening come in handy. There are different levels of screening from between the spectrum of normal and blindness. It can happen in patients who don't have the diagnosis of diabetes, so essentially opportunistic case finding for patients who see the optometrist to get their glasses updated. They have their eyes checked out, and incidentally, they have some retinal changes suggestive of diabetic retinopathy, and then they get referred on and have further diagnosis, further investigations for diabetes, and the diabetes would be diagnosed opportunistically. But in another group of patients, they already have been diagnosed with diabetes, and they require to have screening. And in another further stage, a more advanced disease, the diabetic eye disease has already occurred, but they still require to have monitoring, and they may need to have further intervention to prevent the blindness to occur. So these are different levels of intervention. So the sooner the better. So if we intervene at D is the best probably outcome, but if we intervene at stage A, it would be second best outcome, be better than C, and C is the worst outcome essentially. So that would be the time when the horse is already bolted and the damage is already occurred, and we are just trying to minimize the damage. How about the treatment? Do you know any kind of treatment for diabetic retinopathy? What kind of management are you aware of? So if you've got any patient with diabetes, PRP, photocoagulations, that's correct. Excellent. Anything else? So it's essentially laser treatment, which we come on to that in a moment. Yeah, laser, that's correct. Yeah. Yeah, intravitreal anti-VEGF. Yep, that's absolutely right. What else? How about the things I mentioned about cardiovascular risk factors? Do you think that would play a role? So obviously, you need to make sure that diabetes is optimized and all the cardiovascular risk factors are controlled as well. Actively advise patients, counsel patients with respect to smoking, encourage them to have more active lifestyle as well. Well done. So again, the treatment is targeted at these underlying pathophysiological issues which can affect during the diabetic retinopathy. So laser treatment, as you rightly mentioned, is one of the mainstay treatment once the damage is already occurred. So we can aim for maculopathy for central part or proliferative diabetic retinopathy. For maculopathy, there are gentle burns to essentially seal off the leaky blood vessels and stop them being leaky. They're usually painless, and they are more gentle compared to the treatment which we deliver for proliferative diabetic retinopathy. For proliferative diabetic retinopathy, the aim is to kill off some of the unhealthy retina on the peripheral edge, essentially sacrifice them to maintain the central retina, which is more important for central vision and eyesight. Therefore, we go for the killer laser burns, and they are more painful, and they usually applied on the peripheral retina. The number of laser shots is around about 3,000, whereas for maculopathy is around about in the region of 100, 150 burns. So what's happening here? Anybody would like to describe this image? What are we looking at? Is it the eye we are looking at, or is it something else? Is it the tiger skin we are looking at? Yeah, exactly. Well done. So this is essentially retinal laser skulls, or PRP, which stands for pan-retinal photocoagulation. So essentially, you apply laser to the peripheral retina, you sacrifice the peripheral retina in order to maintain the eyesight in the central part. And usually, unfortunately, you have to be quite brutal. This is old style laser, newer types. This is another old style retinal laser. Essentially, it has annihilated peripheral retina, and as you can see, if you look more closely, you can see some macular burns, macular laser scars visible here as well. Whereas this is a newer type of laser. It's called Pascal pattern type of pattern-guided laser treatment, which are gentler to the retina, and it can be performed quicker compared to old-style Pascal argon laser treatment. With the advent of anti-VEGF in late 70s, late 60s, the treatment paradigm changed completely when it came to diabetic retinopathy, and nowadays there are several different types of anti-VEGF available in the market, which is utilized to treat and manage various aspects of diabetic retinopathy, and not only diabetic retinopathy, but also retinal vein occlusion and macular degeneration as well. And the future is quite bright, and we are moving towards precision medicine. So essentially, with the advent of information technology, better access to genetic risk factors for diabetic retinopathy, we would be able to deliver more individualized care to patients and start treatment in more timely manner for appropriate patients. That brings us to the end of my talk. I'm happy to take any questions. And if you wanted to ask me any questions later on, feel free to drop me an email. I'm more than happy to get back to you later on.